Next up, we have Amar Bhide. I have the pleasure of working with Amar at St. George's. He's a consultant obstetrician and in fetal medicine with me. He is also the deputy editor-in-chief of Acta, Obstetrics and Gynecologica, Scandinavia, and really quite an internationally recognized expert in placenta accreta spectrum. Amar, we've asked you to talk about placenta accreta because we all now acknowledge that that is the consequence of a certain proportion of CSP diagnosis made in the first trimester. Thank you, Amar.
Bashki, thank you very much for the kind introduction. Can you see my slides at all, Haris?
Yes. Yeah, we can see your slides, yeah.
Fantastic. Thank you for the kind invitation to talk about expectant management of cesarean scar pregnancy and placenta accreta spectrum. In some ways, I'm feeling like an odd man out because I don't really see cases with cesarean scar pregnancy. What I do see is the result or sequelae of a cesarean scar pregnancy, and I've got to deal with it, and that's one of the reasons I think I've been asked to speak about it. So to summarize the scope of my talk, I talk a little bit about natural history of cesarean scar pregnancy, treatment options for the sequelae of cesarean scar pregnancy, that is the placenta accreta spectrum. I'll touch a little bit on screening for cesarean scar pregnancy, should we or should we not? And lastly, I would tell you a little bit about our experience about screening for placenta accreta spectrum in pregnancy. So that's in short a summary of my talk today. Right at the beginning, let's revise the diagnostic criteria for cesarean scar pregnancy. And to begin with, we weren't quite sure as to what the diagnostic criteria should be. But now the diagnostic criteria are fairly uniform and well recognized, that the upper uterine cavity should be empty. The gestational sac or trophoblast should be located anteriorly at the level of the internal os, covering the cesarean section scar. The myometrium between the gestational sac and the bladder should be thin or absent, and there should be prominent trophoblastic or placental circulation around it. Finally, the endocervical canal should be empty. So these are the criteria which have been used for calling as a pregnancy a cesarean scar pregnancy in majority of the publications that I have seen. Now, in 2020, the Society for Maternal and Fetal Medicine in America came out with this document, a consult series about cesarean scar pregnancy. And in this document, they realized and acknowledged that there is limited information about this one, particularly the natural history. And the majority of the reasons, the main reason for that is the vast majority of these will undergo termination. So we don't know what happens to them had they not been terminated. But they realized and acknowledged that there is a high risk of severe complications in the second and the third trimesters, and there is a high risk of subsequent development of placenta accreta spectrum. So all this has been recognized and acknowledged in this particular document. Now, this paper published in 2015 comes from the group of King's College. Nurit published this in 2015, and that's one of the first ones I have seen about natural history of early first trimester pregnancies implanted in cesarean section scars. And the criteria I told you about earlier on have been taken from this paper. Now, it is quite interesting to see the data that the authors published in this paper. They followed up 10 women diagnosed with cesarean scar pregnancy, and they were managed conservatively because these women did not want to undergo termination. So 5 of these women ultimately had placenta previa. 5 of them, of the 10, required a cesarean hysterectomy. What's important is the complications. Urological injury was noticed in 5 of them. 4 of them, bladder was injured, and 1 of them, bladder and the ureter, was injured. 6 women showed placenta accreta spectrum on histopathology. All but 3 women had either a blood loss of more than 1.5 liters or a urinary injury or a hysterectomy. So we can see that 70% of them have had severe complications as the pregnancy progressed. The second paper that I have selected for this is cesarean scar pregnancy in the UK, a national cohort study, and this was published in 2018. And they followed up 21 cases of cesarean scar pregnancies that were managed conservatively. Now, 9 of them had cardiac activity and a live birth. So 5 of them with cardiac activity had a live birth. 3 underwent cesarean hysterectomy, 2 of them with estimated blood loss of 15 liters and 20 liters. 1 went through an uncomplicated pregnancy. And the last one, it's an interesting one. It was a heterotopic pregnancy. So the non-viable cesarean scar pregnancy was non-viable. It didn't continue. The other pregnancy, heterotopic pregnancy, continued till term and was pretty uncomplicated, but actually, I don't think this counts as a cesarean scar pregnancy. So one can see that the vast majority of them end up in severe complications as the pregnancy advances. So now there is a fair amount of literature which shows that a cesarean scar pregnancy, if untreated, there's a high chance, 70-80% chance that they will end up into placenta accreta spectrum as the pregnancy advances. And this is what we see if we don't treat the case. And this is what I see. These are the pregnancies that I see. And here is a grayscale image. And on grayscale itself, one can see that there is placenta previa. The placenta has multiple lacunae. I haven't actually put color on, but this picture is good enough. Clip is good enough to tell me that we are in trouble. This is a case which is highly likely to have severe complications as the pregnancy advances. Let us talk a little bit about management strategies for placenta accreta spectrum. And at the moment, we know that there are several options available to us: hysterectomy, fundal incision and leaving the placenta in situ, a staged procedure, so fundal incision and leaving the placenta in situ, and then go back and do a hysterectomy. And finally, partial myometrial excision, a conservative type of surgery, what is called as a triple P procedure that originates from my hospital, St. George's Hospital. At the moment, we don't actually know what is the best way to treat cases where antenatal diagnosis of placenta accreta spectrum has been made. And this document, placenta accreta spectrum document, comes from Society for Fetal Medicine in 2018 and Obstetric Care Consensus. And they say that the most generally acceptable approach to placenta accreta spectrum is caesarean hysterectomy with the placenta left in situ after delivery of the fetus. Worldwide, this is the most commonly performed procedure for placenta accreta spectrum. But let's see what happens to these cases where the primary treatment is hysterectomy. And here is some of the series. The latest one, 2020, 34 cases, cystotomy in 2 maternal deaths. Shamsir, this is one of the biggest ones, comes from Houston in America, 118 women operated, cystotomy 41, ureteric injury in 2. Fitzpatrick comes from the UK, 79 cases operated, ureteric injury in 10, fistula in 4. So you can see that, operating on them, doing a hysterectomy is associated with a fair amount of operative complications in them. What about partial myometrial excision? What can we do with that? And this is a series. Again, the biggest series comes from Jose Palacios from Argentina. And he reported on 326 women, but some of them had undergone hysterectomy. 98 of them had undergone hysterectomy. Majority of the complications that he is describing happened in this group, hysterectomy group. 47 cystotomy, 4 ureteric injury. Our group from St. George's reported our experience of 50 cases, first 50 cases, And we reported cystotomy in 1, reoperation in 1, thrombosis in 3, but we did not report any ureteric injury. So in our hands, the rate of complications is fairly low with partial myometrial excision. The advantages of partial myometrial excision are fundal incision improves access, devascularization limits blood loss, retaining minimal placental tissue limits delayed complications such as sepsis and secondary postpartum hemorrhage, and future childbearing is not the primary objective. We are not doing this in order to preserve fertility. We are doing this in order to reduce surgical complications. Now let's see what happens to those where the placenta is left in situ and not taken out at all. So here is there are some numbers. The latest figures are from 2019, 156 women, 21 of them needed delayed hysterectomy. And if they did need a hysterectomy, the surgical complications happened. Cystotomy happened in 37 of them. 2 women lost their lives. And you can see that reoperation is often required because of sepsis or hemorrhage, secondary hemorrhage, and then surgical complications do happen in those where the placenta is left behind. Here, out of 167 cases, you can see, again, this is the French group, severe maternal morbidity was seen and delayed hysterectomy was needed in 36 of them. So at the moment, we don't know what is the best way to treat them. We know that there are several ways, but we don't have an firm answer right now. That brings us to some of the questions. Should we screen for cesarean scar pregnancy? Is early detection and treatment less risky? And should we screen for placenta accreta spectrum? So there are some factors or some arguments for screening. That's yes for screening. We know whom to screen. Women with previous 1 or more cesarean delivery is an at-risk group, and we know that they have a higher chance of developing a cesarean scar pregnancy. High proportion of pregnancies with cesarean scar pregnancy will proceed to placenta accreta spectrum, and we know that. The rate and severity of complications increases in later pregnancy, and the management of cesarean scar pregnancy in the first trimester is much less risky. I'm not going to go into details about that, and we've got excellent speakers to follow, and we will learn from them how cesarean scar pregnancy should be managed. But this is the only one side of the coin. There is the other side of the coin. Whom to screen is uncertain, and why I'm saying that? Because not all cases of placenta accreta spectrum have got a previous cesarean section. And if we look at published series, up to 50% of them don't have a cesarean section or placenta previa. So skeptics might say that actually, even if you screen all women with previous cesarean section, you're not going to target every case with a placenta accreta later on. There will be a significant increase in workload for ultrasonographers and their trainers, because they have got to be trained properly in order to correctly identify a cesarean scar pregnancy. The hit rate is likely to be low. Most pregnancies following a cesarean section are not going to be placenta accreta spectrum or cesarean scar pregnancy. They are likely to be intrauterine normal pregnancy. Some pregnancies, even if they are diagnosed or detected to have cesarean scar pregnancy, will not develop placenta accreta spectrum. And at the moment, we don't know which one will and which one won't. Finally, there is little evidence that screening does more good than harm. So there are, arguments on both sides of whether or not to screen for cesarean scar pregnancy. That brings me to my final point: should we screen for placenta accreta spectrum? And I wanted you to take through our experience, which we published early this year, on screening for placenta accreta spectrum in women with low-lying placenta. So women undergoing screening ultrasound, and we included 57,000 of them. Now, placenta previa in the 3rd trimester was diagnosed in 220, and that brings us to the prevalence of about 4 in 1,000. which kind of matches what has been reported in the literature. So we weren't missing, we weren't excessively diagnosing women with placenta previa. So these are women with placenta previa. Now, out of these 220 women with placenta previa, 75 of these had previous uterine surgery. And of these 75 women with previous uterine surgery, we had 21 out of the 22 cases of placenta accreta spectrum, and they were correctly diagnosed when they were referred to the placenta accreta diagnostic service. There was only one woman with placenta accreta spectrum who did not have a previous cesarean section, and she had a previous myomectomy. So this is the experience from St. George's about screening program. And what do we learn from it? We learned that 1 in 5 women had previous cesarean section in our cohort. The overall risk for placenta accreta spectrum in these women where placenta previa is diagnosed at 32 to 34 weeks was about 5% overall across the board. We know that 20 out of 22 cases of placenta accreta spectrum had a previous cesarean section. We know that in this group, the risk for placenta accreta spectrum, if a woman has had a placenta previa and 1 previous cesarean section, is 15%. That risk increased to 37% with 2 or more cesarean sections. So this is our experience about screening of women with previous cesarean section and placenta previa to detect a placenta accreta spectrum. And I hope I've convinced you that in the large majority, we will be successfully detecting them in time. Thank you very much.
Thank you very much. Thank you very much, Amar. That was masterful about placenta accreta. Just a couple of questions. You showed some convincing data that placenta accreta spectrum should be screened for. And am I right that that paper shows that you must look for placenta accreta spectrum in women who have both a placenta previa and a previous cesarean section? That was the most efficient way to screen for placenta accreta.
Right. Yes.
Okay. And then you showed quite large data sets. And of course, we're not comparing apples with apples. Some may be different cohorts, but quite large data sets to look at myomectomy, myometrial excision versus hysterectomy, hundreds of cases. But when you come to tell us about what happens to CSP, the number was 5 and 10. Can you be certain about the risk? I'm not arguing with the fact that CSP ends up with placenta accreta spectrum, but can you be certain about the risk that you tell women for placenta accreta when they have a cesarean scar pregnancy?
Baski, I don't know. I can only tell women what has been reported.
Great.
And I showed you what has been reported. The large majority will lead to placenta accreta spectrum if you don't treat them. And that's one of the reasons why a large majority of them will not proceed. They will be terminated.
Okay, so that's why you need to stay on and listen to the next talk. Aris, have you got anything on your screen from that magic screen of yours?
There are hundreds of brilliant questions here, but many of them we will be picking up during the next talks. So okay. I'm going to reserve them. I do want to, though, return at the end of all the talks to this crucial question of, you have a CSP. The woman has an ectopic in the cesarean scar. It's a desired pregnancy, very much a desired pregnancy.
Yeah.
You know, how does your counseling go? Because the mother may say, well, do you know what, doctor, if I end up with a hysterectomy and a healthy baby, that's fine with me. You know, I'm not interested. And that is, you know, for me, a really crucial issue is, can we distinguish those cesarean scar pregnancies that are going to really lead to major hemorrhage during mid-gestation and sort of catastrophic outcomes, versus those women who will actually end up with a live-born infant at the end of it, even though that will mean pretty, you know, valiant surgery at the other end of the gestation. I would love us to try and dissect that. And I know that the data are not there, but if the heads that I have with me today cannot answer that, then I think
we're going to go halfway there.